Chief complaint. This is a case of a 75-year-old female patient who was referred by her dentist for clearance for an extraction given a medication history of anti-resorptive use, Fosamax, about 5 years ago. History of present illness. So the location of this problem tooth was the lower right side, tooth number 29. The root tip with endodontic treatment remains. The duration of this problem tooth was 1 month. She has no pain in this area. The causation of this problem area is infection of root tip in anti-resorptive history. As a side note, she did have a tooth extraction 2 years ago on the left posterior maxilla, which healed with no complication. She is rinsing with a mouthwash, but she's not sure which one it is. And she was recently placed on Augmentin for 1 week duration. Her medical history is positive for diabetes, hypertension, breast cancer 7 years ago, mastectomy done, no history of chemotherapy or radiotherapy. Her current medications are unknown. She did not bring the medications today, but she will bring them next time, along with recent medical studies and lab values. Patient was placed on Fosamax for osteoporosis 4.5 years ago and stopped taking them 2.5 years ago. She has no known drug allergies. For surgeries and hospitalizations, she had a complete mastectomy bilateral due to breast cancer. For the objective exam, under extraoral exam, there was no contributory factors. Palpation of muscles were all normal. Palpation of temporomandibular joint was normal. Salivary glands normal. Lymph nodes normal. There was no lymphadenopathy noted. Her mandibular opening 45 millimeters plus. No joint noises noted. For the intraoral exam, tooth number 29, remaining root. Pressing on the lingual causes pus to come out the socket. There's no abscess or fistula noted. Patient does have a white ropey saliva. For the panoramic film, evidence of ill-defined radiolucency related to root tip of 29 with RCT extending from the crest of the bone to the apex. For the assessment, I diagnosed bisphosphonate-related osteonecrosis of the jaws, or Bronj, radiographic stage number 2. For the treatment plan, patient was examined, findings were discussed, and all questions were answered. I recommended extraction of root tip 29. Patient was informed of possible Bronj infection following the extraction due to past use of bisphosphonates and current radiographic and clinical findings. I discussed the risks and the benefits with this patient. I recommended starting systemic antibiotics 1 week prior to the extraction and 1 week after the extraction. I also recommended chlorhexidine rinse 1 week prior to the extraction and for her to continue using the chlorhexidine rinse until the extraction site was fully healed. So what is Bronj? So Bronj is a condition found in patients who have received intravenous and oral forms of bisphosphonate therapy for various bone-related conditions. It manifests as exposed, non-vital bone involving the maxillofacial structures. It is thought to be caused by trauma in the dentoalveolar structures that have limited capacity for bone healing due to the effects of the bisphosphonates. The inhibition of osteoclast function precipitated by bisphosphonate therapy can lead to the inhibition of normal bone turnover. Now, patients under treatment with oral bisphosphonate therapy are at a considerably lower risk for Bronj than patients treated with IV bisphosphonates. However, in our case, our patient was treated with oral bisphosphonates and still has a Bronj lesion. Patients may be considered to have Bronj if all of the following 3 characteristics are present. Number 1, current or previous treatment with bisphosphonates. Number 2, exposed bone in the maxillofacial region that has persisted for more than 8 weeks. And number 3, no history of radiation therapy to the jaws. So what are the stages of Bronj? For stage 0, there's no clinical evidence of necrotic bone. Nonspecific symptoms or clinical radiographic findings are present. The symptoms include odontologia, not because of an odontogenic cause, a dull achy bone pain, sinus pain, or altered neurosensory function. For clinical findings, we may find loosening of teeth not caused by periodontal disease, periapical or periodontal fistula not associated with necrotic pulp. For radiographic findings, the alveolar bone loss/resorption not because of periodontal disease, dense, woven, or persistent unremodeled bone in extraction site, thickening of PDL, narrowing of IA canal. Systemic management with pain medications and antibiotics may be needed. For stage 1 Bronj, the signs and symptoms, we have exposed and necrotic bone is present, asymptomatic with no evidence of infection. The treatment would include antibacterial mouth rinse, clinical follow-up on a quarterly basis, and patient education and review of indications for continued bisphosphonate therapy. Stage 2 Bronj. So this is the stage we diagnosed for our patient. So the signs and symptoms would include exposed and necrotic bone present, pain, and clinical evidence of infection. Treatment would be oral antibacterial mouth rinses in combination with antibiotic therapy, pain control, and superficial debridement. For stage 3 Bronj, the signs and symptoms include exposed and necrotic bone present, pain, infection, and one or more of the following: exposed necrotic bone extending beyond the alveolar bone area, pathologic fracture, extraoral fistula, oral antral or oral nasal communication, osteolysis extending to the inferior border of the mandible or sinus floor, and the treatment would be antibiotic therapy and pain control, surgical debridement, and or resection. So for this patient, the medications and follow-up. Medications include amoxicillin 500 milligrams, 42 tabs, 1 tab TID, and RX chlorhexidine oral rinse 0.12%, 1 bottle, rinse with 1/2 ounce 3 times a day, no food or water for 30 minutes. In the follow-up for this patient, we'll have the patient return to the clinic in 1 week for root tip extraction of tooth number 29. We wanted her to be on the antibiotics 1 week prior to the extraction. Patient returned 1 week later for extraction of the root tip. She's taking the antibiotics for 1 week and rinsing with the chlorhexidine rinse, and there were no side effects reported. No changes in signs and symptoms. Original comprehensive exam was repeated and no changes were found. For the treatment plan, patient was examined and all questions answered, informed consent for biopsy and local anesthesia obtained, 1.4 ml lidocaine, 1 to 100,000 epi was used, tooth extraction in 1 piece, curettage was done, local antibiotic arrestin was placed, 1 suture using 4O silk was placed to close the surgical site. Good hemostasis was achieved and written post-op instructions were given to the patient. For the follow-up, the patient's to return in 1 week for suture removal, an examination of the surgical site for healing or complications. Patient will continue taking the medication prescribed in the last consultation. That was the amoxicillin and the chlorhexidine rinse. Visit number 3. Patient returns for suture removal. Extraction site healing well. Patient was advised to continue using the chlorhexidine rinse until the site is fully healed. This is very important. A follow-up for this patient is to return in 1 month to evaluate the extraction site.